Yes, sir. 3, 2, 1, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we will discuss genitourinary tuberculosis, and this would be presented by our president, Dr. Sarthak, and would be moderated by our faculty, Dr. Kuldeep. So I would request Dr. Sarthak to kindly share his presentation.
Thank you, sir. Good morning, everyone. I'm Dr. Sarthak Sharma, and I'm going to be presenting this seminar on genitourinary tuberculosis. Tuberculosis, the history is very prolonged, and the earliest written records have been found in China and Indian subcontinent, dating back to 3,300 years ago. But it was not until the 18th and the 19th century that it reached the epidemic proportions. On March 24, 1882, Robert Koch was the first one to isolate the tubercle bacillus, and this day is being celebrated as the World Tuberculosis Day. Coming to microbiology, tuberculosis is caused by a group of acid-fast bacteria, with most commonly Mycobacterium tuberculosis and Mycobacterium bovis causing the human TB worldwide. The difference between them is not in the clinical disease, which will be indistinguishable, but the drug susceptibility patterns differ with the variants. Now, genitourinary tuberculosis is the second most common extrapulmonary site after lymph nodes, and more than 90% of the cases are present in the developing countries. There is a concurrent pulmonary TB infection in them in 15 to 20% of cases in developing countries and 2 to 10% in the developed countries, and men are more involved as compared to the females. The primary urinary organ is kidney, while the primary genital organ in males is epididymis and fallopian tubes in women. How does the genitourinary TB spread? The principal route is hematogenous spread, and it goes to kidney and epididymis, and from there are ascending or retrograde infection to the other organs. There is a contiguous spread also, that is spine TB can go to the kidney, and a GI tract TB can form a fistula and enter the kidneys as well as the bladder. There is also a direct inoculation method where infected stools in urine or person-to-person genital contact can transmit tuberculosis. Now, infected aerosols, they reach the alveoli where they are either killed or they replicate in the macrophages, and via the lymphatics and hilar lymph nodes, they enter the bloodstream and reach the genitourinary tract. Now, presentation of genitourinary tuberculosis is highly variable. They may present with recurrent or resistant UTI or irritative voiding LUTs. They may be an incidental finding in a person having a history of tuberculosis. They may present with hydronephrosis, pyonephrosis, or an epididymal mass, infertility or a pelvic inflammatory disease in a female, and they may also present with renal failure. Most common symptoms are frequency, urgency, dysuria, which is present in approximately 50% of the cases, while the classical symptoms of the tuberculosis like fever, weight loss, night sweats are present in less than 20% of the cases. Coming to kidney, 80% of the time in the urinary system, kidneys are affected. The bacilli reaches the periglomerular capillaries and lead to granuloma formation first in the cortex, then the medulla is involved and the collecting system gets involved. Now, kidney eventually will become non-functional, and it is seen in up to 33% of these cases. The autonephrectomy can be of caseo-cavernous type, where granulomas with or without calcification will be found, or a fibrotic type, where a scarred and shrunken kidney will be observed. End-stage renal failure occurs in 7% of these cases. Infection to the ureter is a descent of infection from kidneys, and the granulomas, they will form along the walls. More commonly, the lower ureter is involved near the vujae. However, entire ureter can also be involved in a panureteral fashion, and eventually, if it is untreated, it can also lead to renal failure. Infection to the bladder, if it is coming from an infection descending from the kidneys, it first reaches the urethral orifices, and from there, via the lymphatics, it reaches to the other sides of the bladder, thus causing a patchy cystitis. And ulcerations can eventually develop. Most commonly, the dome of the bladder is involved, and trigone and neck are the areas which are usually spared. Eventually, the bladder capacity decreases and the frequency, urgency, and other irritative LUTs features become more prominent if the capacity decreases to less than 100 ml. And if the capacity becomes less than 20 ml, we call it a thimble bladder. Bladder contracture eventually develops, but it is a very late complication of genitourinary tuberculosis. Coming to the genital system, in males, epididymis is the second most common site of genitourinary tuberculosis, and initial involvement is of globus minor because it is highly vascular. Clinical findings will be of a nodular beaded appearance of the vas, and there may also be a presentation in the form of scrotal sinus on the posterior aspect of the scrotum. Isolated infection to the epididymis or testis is rare. If the testes are involved, they will mimic testicular tumors because they will present with a painless mass. Prostate and seminal vesicle. Prostate gets involved either by a hematogenous spread or a urinary contamination. If it is via the hematogenous spread, there will be more peripheral lesions and calcification and glandular hardening. And if the urinary route is followed, then the urethra is getting first involved. Seminal vesicles, they also may get an ascending infection from the genital tuberculosis via the vas deferens or a descending infection via the urethra and the ejaculatory duct. The patient usually presents with a low volume ejaculate, oligospermia, azoospermia, or hemospermia, and the physical examination will reveal an enlarged seminal vesicle during the early stages or hardened nodular appearance in advanced cases. Urethra and penis are two organs which are relatively spared by the tubercle bacteria. In penile lesions, you can find pea-sized nodules on the cavernous bodies, which will be painless and hard, and or you may find a fungating mass. But when the fibrosis develop, the structure of the penis may get distorted and patient might feel erectile dysfunction. Now we have a whole array of investigation ranging from blood, urine, and radiological investigations. Coming to urine routine analysis and culture, urine routine will show a sterile pyuria with microscopic hematuria and an acidic pH, while the routine culture will come out to be negative. The first line diagnostic test is a urine AFB smear, which has a sensitivity of less than 50%. However, the specificity is up to 100%. How do we collect the urine? We have to take an early morning clean cat sample in a sterile glass container, and it should be analyzed within 2 to 4 hours. And it is important to take multiple samples for 3 to 5 days for maximum yield. The pH of the urine is found to be acidic because of mycolic acid, and this urine for AFB staining is projected for Ziehl-Neelsen staining for acid fastness. The gold standard still for genitourinary tuberculosis is a urine AFB culture, which has a sensitivity of 80 to 90% and a specificity of 100%. We have both solid as well as liquid medium. Liquid medium is more preferred nowadays, but we combine both solid and liquid medium for maximum yield. LJ medium, Middlebrook 7H10, and a Bactec MGID medium are more commonly performed. Nucleic acid amplification tests, they have an advantage that the results are delivered within 1 to 2 years, 1 to 2 days, and there is detection of the low bacillary load where cultures might fail. But here the disadvantage is urine has natural inhibitors that prevent DNA RNA amplification, thus sensitivity is reduced. It is recommended as an adjunct, but it cannot replace culture for diagnosis. CBNAT, it is a cartridge-based nucleic acid amplification test, which WHO recommends as part of the initial workup in all patients. It has a sensitivity of 83 to 95% and a specificity of 79 to 99%, and results are delivered within 2 hours. Histopathology, if you take a biopsy and see histopathologically, then you can find caseating granulomas composed of epithelioid and Langerhans giant cells surrounded by lymphocytic background. And mycobacteria are usually not seen in these specimens. If patient has an epididymal nodule, FNAC can help, which is diagnostic in about 67.5% of the cases. There are some screening tests, mainly tuberculin skin test and IgRAs, but the disadvantage here is they cannot differentiate between a latent and an active TB infection, but they are still recommended by FDA. A positive test cannot rule in a TB and a negative test cannot rule it out. Tuberculin skin test. Here, a tuberculin protein is extracted from Mycobacterium tuberculosis, and it is intradermally injected into the volar aspect of the forearm. And within 72 hours, there will be a delayed type hypersensitivity and induration formation in an already primed patient. Now, when the test is said to be positive for general public, if an induration of more than 15 mm is there, then it is said to be positive. While if there are high-risk workers such as healthcare workers or immigrants from high-risk areas, then an induration of even 1 centimeter is said to be positive. And other high-risk conditions such as patients with HIV, patient having previous contact, patient having recent contact, patient having previous history of tuberculosis in duration of even more than 5 mm is considered positive. Now, interferon gamma release assay is a blood test which measures the level of interferon gamma against the TB antigen, and the results are found within 24 hours. Coming to radiology, ultrasonography has a very limited role in the diagnosis, but it detects the anatomical changes that occur in genitourinary tuberculosis. Like in the image given below, you can appreciate that there is hydronephrosis, calyces are dilated while the pelvis is not dilated. It can also detect perinephric abscess as well as psoas abscess, and it has major role in pediatric and pregnant patients and in the evaluation of genital tuberculosis of testis and epididymis and prostate and seminal vesicles by doing a truss. Plain X-rays usually you will find calcification in more than 50% of the cases. In kidneys, it starts with a faint punctate calcification and progresses to globular calcifications. If there is a triangular ring-like calcification, it is suggestive of papillary necrosis. And during the end stage disease, the kidney become very small, shrunken, cement or putty-like. The ureteral calcifications are usually intramural, and it is an important differentiating point from schistosomiasis, where mural calcifications are usually found. Now, a chest X-ray is very much important while taking an X-ray KUB, because 15 to 20% of the cases have an concurrent pulmonary tuberculosis. Intravenous urography, it is still the gold standard for early renal tuberculosis, and CT urogram is fast catching up, but it can only detect make a diagnosis with certainty only if the lesion has ulcerated into the calyx. Now, intravenous urography, the earliest sign is the moth-eaten appearance, where calyceal erosions are found, and eventually these will communicate with the collecting system. There will be stenosis, stricture formation of the infundibula, leading to localized calyectasis and phantom calyx formation, and the renal pelvis becomes hiked up and scarred, giving an appearance of Kirk's kink. This is an image depicting moth-eaten appearance, which is the earliest abnormality found on IVP. This image shows fuzzy and feathery calyx due to papillary necrosis. This again is an IVP image showing a blunted calyx on the left side and a moth-eaten appearance on the right side. This image depicts a hiked up pelvis, showing an appearance of a scarred pelvis, Kirk's kink. This again is an image of a hiked up pelvis. This IVP image shows pan-ureteral involvement with pipe stem ureter. And this is usually the end stage of the GU tuberculosis, that is a putty kidney. Coming to CT scan is replacing IVU as imaging of choice because it is equally good at identifying calyceal and infundibular abnormalities and parenchymal destruction as well as complications. And added advantages, we can analyze the other structures as well, such as adrenal, retroperitoneum, prostate. This axial image on the left side is showing a caseous tuberculous cavity, and on the right side, the coronal image shows that the right kidney is not visualized, that is, it is non-functional. These axial sections are showing a perinephric collection, and along with the coronal section, you can make out that where the cavity have ruptured. This coronal image is showing multiple findings. You can find that there is no pelvic dilatation, there is parenchymal scarring, there is cavity communicating with the PCS, there is urothelial thickening, as well as multiple ureteric narrowing. This again is a coronal section showing that tuberculosis is involving the entire left system, and there are severe non-uniform calyectasis and strictures involving the pelvis and ureter. There are some disadvantages or rather limitations of CT scan. That is, it is less sensitive during the early renal tuberculosis stage, where the IVU is still the preferred modality. In addition, CT imparts a high radiation dose as compared to IVU, although this has been taken care of. Now, MRI in GUTB, it is not commonly performed. It is only indicated if the person has a compromised renal function or in a pregnant and pediatric patient or a patient having allergy to contrast media. It has equal importance as when we compare it to CT, with good morphological detailing of the kidney and excellent delineation of the ureters, and it can even detect a single granule. Coming to retrograde and antegrade pylography, only there are two indications One is when you want to lateralize the disease by taking a urine sample, and second, when you want to delineate the length of the ureter involved by the TB. If the retrograde axis is not permissible, you can take a percutaneous integrated axis. Coming to cystoscopy and bladder biopsy, cystoscopy has a limited role in diagnosis because findings are very non-specific. You will find an inflamed bladder with a reduced capacity and a patulous urethral orifice, which has a very high chances of perforation. Diagnosis of GUTB can be made only up to 46% of these cases, and biopsy is indicated only when you have a suspicion of malignancy. Important here is when you are taking a biopsy, you have to take two samples. One is formalin fixed and the other is sent in normal saline. Now, these are some of the cystoscopic images. The important is image C, where you can see a tuberculous bullous granulation, and image E, where you can find a golf hole ureter, and image G showing an healed tuberculous scar. These are some of the laparoscopic and hysteroscopic views in female genital tuberculosis. On the left, you can find that the TB in laparoscopic view, you can find hydrocephalings with beaded fallopian tubes. And down, you can find granulomas involving the uterus and the fallopian tubes. While on the right, you can see in hysteroscopic view showing intrauterine adhesions. Coming to algorithms, the National TB Elimination Program gives algorithm for both urinary as well as genital tuberculosis. If a patient comes to you and you have a clinical suspicion, you will go ahead with a urine routine microscopy, urine for AFP culture, gene expert, urine culture, and a USG KUB. If it comes out to be negative, but your clinical suspicion is high, you can go for a second attempt by microbiology. And if it still comes out to be negative, you can go for imaging by checking the renal function and deciding between a CT scan or an MRI. And if it comes out to be positive, you can start with an anti-tuberculosis therapy. Male genital algorithm, the usual presentation is by scrotal pain, swelling, and sinuses, along with the urinary complaints. The patient usually have a thickened epididymis or a hard nodular prostate or a non-tender testicular mass. The diagnostic tests performed are the same as we do for urinary tuberculosis. And if it comes out to be positive, we can start the patient on anti-tubercular therapy. The female genital tuberculosis usual presentation is infertility, abnormal uterine bleeding, fever, weight loss, which is present in less than 20% of the cases. On examination, you can find an abdominal or tubo-ovarian mass. Here, additionally, you will take a premenstrual endometrial sampling for smear, and a USG pelvis is performed along with the urine and gene expert. If it comes out to be positive, you will start the patient on ATT. If it comes out to be negative, but you still have a clinical suspicion, you can go for laparoscopy with or without hysteroscopy, or USG and CT or MRI. And if it comes out to be positive, you can start the patient on ATT. If it is showing high suspicion, also you can start with ATT. Coming to treatment part, GUTB can successfully be treated with a short course of 6 months with first-line anti-tubercular drugs. These are the first-line anti-tubercular drugs. The rifampicin, isoniazid, pyrazinamide are all bactericidal, while ethambutol is a bacteriostatic agent. Rifampicin and pyrazinamide, they both act on semi-dormant bacilli and they are responsible for preventing relapse, while isoniazid acts very fast and it prevents the emergence of drug-resistant mutants. The treatment phases in NTEP program is intensive and the continuation phase. The intensive phase kills the rapidly multiplying bacteria, while continuation phase acts on dormant, semi-dormant bacteria. These are the treatment regimens based on the weight band category and fix those combinations that are available under the NTEP program. These are some of the second-line anti-tuberculosis drugs which have been grouped according to the efficacy, experience of use, and the drug class. Coming to special conditions, multi-drug resistance, MDR-TB is said to be when there is resistance to both isoniazid as well as rifampicin, and it is found in about 3.3% of newly diagnosed cases and 20% of the patients having previously been treated. The cure rate is around 50 to 60%, and the regimens are usually longer than 18 months. In XDR-TB, they will be resistant to isoniazid, rifampicin, any fluoroquinolones, and at least one of the injectable second-line aminoglycosides. And the treatment here gets complicated and cure rate falls down to 30 to 50%. In cases of pregnancy and lactation, if a patient is being treated for tuberculosis, pregnancy should be avoided. But if a patient is pregnant and is being diagnosed with tuberculosis, you should start therapy because the risk of fetus developing TB outweighs the risk of adverse drug reactions. The treatment usually is for 9 months. If in a postpartum phase, the women can be allowed to breastfeed once she becomes non-infectious because the drug concentrations in breast milk are too low to cause toxicity to the infant. HIV patients, the risk of active tuberculosis is 30-fold in these patients. Therefore, all TB patients should be tested for HIV. The problem here is there will be a more disseminated tuberculosis with bilateral involvement, but there will be less caseation, necrosis, fibrosis, and stenosis because competent immune system is lacking in these cases. Treatment guidelines are similar. 6 months short course therapy is enough. But if the patient is not taking consistent antiretrovirals, you can prolong the treatment to 9 months. Drug interactions should be considered and should be dealt with. Renal transplant recipient, a renal allograft TB is rare. They usually present within 6 months, but the diagnosis can be made up to 7 years also. In these patients, diagnosis is difficult because signs and symptoms are usually absent and the urinary symptoms are present only in 20% of the cases. Histopathology may help in making a diagnosis, and the treatment is complicated by drug interaction between rifampicins and the immunosuppressive drugs. Dose modifications in renal failure. In renal failure, ethambutol and streptomycin will require dose modification. However, isoniazid, rifampicin, and pyrazinamide are excreted in bile, and no modification is required in them. Coming to the surgical part, surgery is usually required in 55% of the cases to either relieve the obstruction or drain any infected material, or nephrectomy for a non-working infected kidney resisting treatment, or a resistant hypertension secondary to a functionally excluded kidney, or for reconstruction. Majority of surgeries that we do are for reconstruction, which is more than 50%. And the optimal time of surgery is 4 to 6 weeks after initiation of the ATT, because now the active inflammation would have subsided, the bacillary load would have decreased, and lesions would have stabilized. What are the procedures to relieve obstruction? First, you will go for temporary method in the form of stenting, DJ stenting or PCN placement. And when the renal function improves, you will go for definitive management in these cases. Nephrectomy. The goal in genitourinary tuberculosis is organ preservation always. Total nephrectomy is indicated in 2 settings that we already discussed: a non-functional kidney with a recurrent tuberculosis or a recalcitrant infection despite optimal treatment. And after nephrectomy, the relapse rate falls to less than 1%. And if there is a medically resistant hypertension, where after nephrectomy improvement will be found in 65% of the cases. Coming to the PUJ and the urethral surgery, the strictures, usually we will perform stenting, and when renal functions improve, we will go for definitive management. The upper and mid-ureteric strictures are rare and they are amenable by endourologic treatment, while the lower ureteric strictures, which are more common and they are more problematic, and they usually require open surgical intervention. Endoscopic management. Tuberculous strictures are usually composed of mucosal ischemia with dense fibrosis. The best outcomes are in the patients with short strictures and residual lumen with a good renal function. You usually perform a dilatation and DJ stenting, but there are high failure rates. Therefore, repeated procedures are usually required. You will follow up these patients because the strictures may worsen on being on medical therapy because of fibrosis and cicatrization. And in these cases, corticosteroids may be added. But if there is a failure or progression, even after 6 weeks of ATT, you can plan for an open surgical management. Open surgical options are reserved for long and complex strictures. And in the cases of PUJ, if there is an extrarenal pelvis with a short segment scarring, you can go for dismembered pyeloplasty. But if there are long strictures, you need to do a non-dismembered pyeloplasty. And if nothing works and anatomic reconstruction is not possible, ureterocalycostomy is again an option. In cases of both upper as well as lower ureteric stricture, excision with primary tension-free anastomosis is preferred. In lower ureteric strictures, for additional 2 to 3 centimeter gap, you can mobilize the contralateral attachments as well as divide the contralateral superior vesical pedicle. And for additional 5 centimeter gap, psoas H can be performed. For 10 to 15 centimeter gap, a Bori flap is indicated. For bladder surgery is usually performed when the capacity of bladder decreases. If it becomes less than 100 ml, then the irritative bloods become very intolerable and augmentation is required in these patients. And when the bladder capacity falls to less than 20 ml, that is a thimble bladder, you might require an orthotopic bladder substitution. The complication after both of these procedures that there will be mucus production, electrolyte derangement, and secondary infection. Urethral procedures for bladder neck contracture, transurethral incision of the contracture can be given. For urethral strictures, you can manage them endoscopically, but repeated procedures are required. For a urethral fistula, you can go for a diversion in the form of SPC with a delayed reconstruction. And for seminal vesicle, you can drain them into the bladder with a cold knife incision. Genital surgery, extirpative surgery for genital TB is considered only when the medical therapy has failed. If the epididymis is only infected and testes are spared, epididymectomy can be performed alone. And if a testis is infected and epididymis is spared, although this is very rare, a scrotal orchidectomy is done. Now, to conclude my talk, this is an ICMR image where to guide you through the workflow. When do you suspect a TB? You suspect it when there are classical features of TB or patient having LUTs, or in the genital tuberculosis, a scrotal pain or swelling, not responding to antibiotics. You will go ahead with the investigations as we already discussed in the form of urine routine, urine AFB routine, urine culture, and gene expert, as well as you will go for radiography and see if there is any anatomical deformity present, and you will guide your treatment accordingly. If no anatomical problem is there, you will start these patients on ATT according to the NTEP program, that is 2 months of HRZD and 4 months of HRE. And in the cases of MDR and XDR, you can follow up with them according to the guidelines. Thank you.
Thank you, Sarthak. That was a good presentation. We all know genitourinary tuberculosis is quite common in our part of the world. And this is, in fact, the commonest infection-related death throughout the globe, throughout the world, right? And almost 10 million people are diagnosed of tuberculosis every year. 1 crore people are diagnosed of tuberculosis. And we talk about extrapulmonary tuberculosis. 1/3 of tuberculosis would be extrapulmonary. And 1/3 of this extrapulmonary could be genitourinary tuberculosis. So overall incidence is around 2 to 20% of genitourinary tuberculosis. We all know the latency period could vary from 5 years to 25 years for genitourinary tuberculosis. And the spread is usually by hematogenous spread, or sometimes it could be lymphatic spread, or by direct contiguous route, or sexual transmissions. So if you know, I don't know how many of you know, he talked about who discovered the tubercular bacilli, Robert Koch, right, in 1811. And then who coined the term genitourinary tuberculosis? Hans Wildbots in 1937. He coined the term genitourinary tuberculosis. So genitourinary tuberculosis has 2 parts. One is genital tuberculosis and one is the urinary tuberculosis. Often they could be separate, right? Not necessarily that every patient of urinary tuberculosis will land up in genital tuberculosis. Both can be separately found, right? So genital tuberculosis again could be found in males and females, and they have different presentations. So when we talk about the symptoms, yes, many patients would present with, usually the renal tuberculosis goes asymptomatic in majority of times. And when it goes into the ureter and bladder, then the symptoms usually appear. So the irritative symptoms of frequency, urgency, nocturia, all these would appear, and burning, etc., would appear usually when the bladder gets involved. So this is called cystitis, and usually it's a pancystitis. And on urine examination, you may find pyuria, and often it is a sterile pyuria. So that is why majority of times patients who present with recurrent urinary tract infection or resistant urinary tract infection, there should be a high index of suspicion for genitourinary tuberculosis, right? And usually they would have sterile pyuria, and many of them would present with hematuria, which could be in majority microscopic and sometimes even gross macroscopic hematuria again. And then they can present with the systemic symptoms also of tuberculosis in the form of weight loss, fever, etc. Important history is taking history of exposure to tuberculosis in the family, whether they were residing at a place where tuberculosis was rampant, or there was somebody suffering from tuberculosis, and past history of tuberculosis. That is very important. So once you have a suspicion of tuberculosis, as I said, urine routine examination for AFB staining, which is very less sensitive. So majority would not. So, and the important is 3 to 6 samples of early morning urine samples, which should be sent for urine smear examination. And then AFB culture. When we talk about AFB culture, we know ZN culture, the solid media culture. But the ideal, the gold standard is the liquid culture. This is called automated liquid culture system. And the other name is MIGT, microbacterial growth indicator tube. And usually the result can come within 2 weeks. Whereas in ZN culture, whereas AFB culture, we usually get at 6 weeks, right? But the usual practice is giving both the cultures. So as you said, to increase the yield of diagnosis. The other common important, as he talked about, the CB0 test or the gene expert, right? Gene expert, as he said, in urine, it may be a slightly kind of not that sensitive because of the presence of urinary inhibitors. But still, there are many studies which have shown that, yes, CB0, and usually it comes under the, we need to do a CB0 test in majority of these patients of genitourinary tuberculosis. Nowadays, we have another gene expert edge kind of a test, which is a POC, that is point of care testing, where within an hour you can get the result. So that's called gene expert edge, point of care testing. Similarly, in CA prostate, we have a POC or serum PSA testing. So once we have this urine testing for culture and staining and smear and CB0, etc., the other tests would be either in the form of imaging, where, as he said, in the earlier part of the disease, the gold standard would be intravenous urogram, but CT urogram is catching up. It's almost as good as an intravenous urogram. So because of its benefits, other benefits of the CT scan, giving it the whole anatomy, not only just the urothelial lesion, because tuberculosis in the kidneys could be either in the urothelium, which is most common, in the pelvic lesion system and the ureter, but it could be parenchymal. Right? So those parenchymal lesions would be picked up by CT scan. They could present as kind of an abscess, they could present as tuberculoma, they could present as calcification, and sometimes, as you said, the putty kidney and cement kidney. Even this is called autonephrectomized kidney, when the whole kidney gets non-functional. And imaging, IVU, as he said, the moth-eaten appearance of the calyces, and if the infundibulum of the calyx gets stenosed, the commonest would be a hydrocalyx, sometimes a phantom calyx. Phantom calyx is one where the dilatation results in a non-functional kind of a, and the tissue gets, so there is a non-functional calyx, so it doesn't get seen on IVU. So it's a cutoff calyx, or sometimes called phantom calyx. And then you could have hydronephrosis due to POJ obstruction. And when the ureter gets involved, you can get lateral strictures. The commonest would be VUJ, which causes hydroureteronephrosis. And sometimes there will be multiple strictures where this gives a corkscrew appearance. on intravenous graft. And if the whole of the ureter gets involved, it's a pipe stem ureter. And then when the bladder gets involved, as I said, there are multiple appearances. Usually, if you could do a cystoscopy, you would find sometimes a inflamed, congested mucosa. Sometimes you would get a sago green appearance, or around the ureteric orifice, edematous mucosa with some lesions. And sometimes it will be a pancystitis. And in the end stage, you would find a small contracted fibrous bladder, which is called thimble bladder. Right? And when we talk about genital tuberculosis, it can involve prostate, seminal vesicle, vas deferens, testis, epididymis, and penis. Right? All these can be involved. So prostate can be involved either from ascending or descending. And as he said, prostates usually, he said about presentation as a hard nodular prostate. But I will slightly differ, because most of these tuberculous prostate would present as a small fibrous prostate. It's not a hard nodular. That's not the usual procedure, what in our experience. And as the book says, it produces a low volume ejaculate due to the ejaculatory duct obstruction. But actually, most of these patients who have prostate tuberculosis will have anejaculation, because the prostatic ducts also get blocked. So total loss of ejaculation, anejaculation, is the commonest finding if the prostate has got involved. And then seminal vesicles can also be in the vas, will give a beaded appearance. And the scrotal nodular lesion sometimes would present as hard nodular epididymis. Sometimes the testis can also get involved. And sometimes they may present with an ulcerative also. So these are the usual presentations. And then the histopathology for finding of the tuberculosis plus this culture of the tissue will actually confirm the diagnosis. So even if the culture is not positive, but your clinical suspicion along with imaging gives you a diagnosis of genitourinary tuberculosis, you can start with the treatment, the usual treatment. It's not necessary that every patient will have culture positive. I think, and there are a few more tests like LAM assay. LAM assay is a test which detects the cell wall protein, and it is usually used in patients with HIV and CD4 positive patients. So these are, I think, this was in brief about the whole chapter of genitourinary tuberculosis, and the treatment part he has already dealt with. The surgical part he has dealt with. The kidney, if it's non-functional, you do a nephrectomy. If it is strictures, you do a reconstructive surgery in the various forms. If the bladder is small, you do augmentation, cystoplasty. And so all these are the reconstructive procedures that we usually do. So I think that's it. So if anybody has residents or faculty, do you want to, Nachiket, if you want to just say something? Kuldeep?
What did you say about that seminal vesicle system which gives incision around the second? What that incision? On what? Seminal vesicle tuberculosis.
So sometimes, as Dr. Nachiket was asking about some, how do you drain that seminal vesicle tubercular cyst, as he said about draining it with cold knife incision through the bladder. So only in cases when there's a large cyst which is protruding through the bladder, and while cystoscopy, you find that there is a protrusion which can be punctured or can be incised, and imaging, you have confirmed that this is a seminal vesicle cyst only, then only you just do that. Otherwise, you can do ultrasound guided seminal vesicle aspiration, also dilated cyst aspiration, as we do for ejaculatory duct obstruction. And that can be sent for AFB smear or culture. So besides urine in genital tuberculosis, we can also send it for the semen, also for culture, AFB culture. Semen is if the prostate and seminal vesicles are involved, the semen can be sent for culture. As in females, we do endometrial biopsy to confirm, or a laparoscopic to confirm. So in females, they usually 90% present with the blocked fallopian tubes, and they present with infertility. In males also, if the bilateral testis gets involved, they could present as male infertility. So the first sign could be an infertility, even in patients or in male patients with genital tuberculosis.
My second question is that all these signs that you get on, like you get them on this, or you get the infection of this or pattern dilatation, would they be better delineated on an IVU, or would they be better delineated on CT urography? Or has CT urography subverted IVU and send it to you publicly? You get all these features on a CT urography also? No, you can get them on CT.
So that's what
Each and every feature on IVU you can get on CT urography. As a matter of fact, now it is oblivious to get an IVU inside this case. You want to characterize them more.
Nachiket, I just told that same thing point. So he is still, the books say the gold standard for early lesions is intravenous urogram, but CT urogram is catching up very fast, and CT urogram gives a picture almost like an IV, almost. So the books still do not say that in early part of tuberculosis, but I think yes, soon it will become the gold standard because of the benefit of CT scan for the anatomy that it, and as I told, there could be a parenchymal lesion. There may not be a urothelial lesion. So it will be picked up only by CT, not by IV.
My third thing is, as you said about the ureteral colostomy, because it's well known, surprisingly, in tuberculosis, the parenchyma of the kidney is maintained even inside advanced cases. And the callosis is very sad. So doing the ureteral colostomy is extremely difficult in a fat parenchyma and in a scarred calyx. So even though it is mentioned inside books, but if you go inside discussions and all, they say that it is one of the most difficult surgeries to do a ureteral colostomy in surgery. So, it's very simple to write on a piece of paper, but if you look at the clinical picture of GUTB, the parenchyma is usually thickened. You can do it very easily in a PUG obstruction. But the ureteral colostomy, because there is also intrarenal scarring. Then if the calyx is scarred, then infantile scarring. Then you have intrarenal scarring also. You don't get that classical, dilated pelvis in a GUT. So this is also there is easier said than done. What difficult it is?
Very difficult. Usually this not required because when you get that kind of advanced tuberculosis, most of them are poorly functioning or non-functioning kind of kidneys. A nephrectomy is a better option in a very poorly functioning kidney. Only in early phases where there is just a localized stricture. So PUJ stricture can happen. So in that case, pyeloplasty, as you said, infundibular stricture can be done by infundibulotomy only. You did not do pylotomy in that or pyeloplasty. So I think early cases, if detected, they can be done that way. Otherwise, most of these patients would land up in nephrectomies. So we will go to the MCQs. All of the following mycobacteria causes tuberculosis except bovis, avium, africanum, microti, and BCG. There's a complex mycobacterium tuberculosis complex consists of what? He has already discussed it, right? So I think this is except avium, right? Avium, because all the other bovis, africanum, microti, and BCG can cause mycobacterium tuberculosis. And BCG is non-tubercular, non-tuberculosis. Anand, can you just come and just shift this? Yeah. So which of the following results most specifically diagnoses genital urinary tuberculosis? A positive interferon Y release assay, a positive urine PCR, a TST reaction of 25 mm, a positive AFB culture, a renal biopsy showing AFB. No, culture. AFB culture is probably the gold standard, no doubt. So the liquid culture is probably even better, MIGT, as we discussed. Positive interferon Y release assay is also called the quantiferon gold assay test. This is more or less same as tuberculin test, the Mantoux test that we do. It tells you about the tubercular infection. It doesn't tell you about the active tubercular disease. So both gold test and Mantoux test will tell about the infection present in that person. That could be a latent infection. It could be a dormant infection, not necessarily an active infection. So they are not actually confirmatory of diagnosis of tuberculosis. PCR, we know, usually we need, but it is less sensitive. Urinary PCR can be done for tuberculosis, but gold standard still remains the TST as a tuberculin sensitivity test, or the Mantoux test tells you about the active infection in the patient and disease infection in the patient, but not the disease. And a positive urine AFP culture, as we said, renal biopsy showing AFP. Definitely, if the kidney shows AFP, bacillus in not so, but they have to be cultured, right? The biopsy is usually the tissue is sent for AFP culture. AFP culture. But the biopsy may not show the AFP bacteria. So when you culture the tissue, it may grow culture, right? But the biopsy doesn't show usually the AFP bacillus. So that's why. But if they had said that the tissue culture for AFP, then it would have been different, right? And next question is, which of the following first line ATT doesn't cause hepatic toxicity? Isoniazid, rifampin, pyrazinamide, ethambutol. Ethambutol causes, doesn't cause. Only the ethambutol doesn't cause? Which? Which of the first line antibiotic doesn't cause hepatic toxicity? Which one doesn't cause? Ethambutol. Wait, that's what I'm saying. Ethambutol doesn't cause. So rest isoniazid causes neuropathy. Rifampin causes hepatotoxicity. Pyrazinamide causes. Okay. And streptomycin causes nephrotoxicity and ototoxicity. Right. So ethambutol is rarely hepatotoxic. Which of the following statement is false about GU tuberculosis? MRI is often used to help diagnose patients with this. CT is most useful in extensive tubercular disease when other organ systems might be involved. The most common finding of GU on plain film is calcification. Intravenous urogram is the best test to detect early renal changes. And the most common finding of IV is obstructive uropathy from scarring, which is false. So MRI definitely is false. It's not often used. It would be used in rarely. But I think the rest of the things are normal. As I said, IVU, CT urogram is catching up. Calcification. Calcification, usually we think calcification means the disease is healing. Is it? In tuberculosis.
Saying the most common finding of GP on plain film is calcification, which is
so this is true. So which is false? That's we are trying to ask, right? So A definitely A yoga. I'm talking about calcification. So calcification in tuberculosis doesn't mean that it's in a healing process. Calcification means there's an active disease. Usually this calcified tissue has active bacteria which can give rise to more infection. So that is important about calcification. So MRU is often used to help diagnose patients. The most common site of ureteric stiction in GUTB is distal ureter, right? So it's the VUJ, vesico-ureteric junction, because it's the narrowest part, right? I think that's it. So thank you. Thank you once again. So if anybody who has joined us wants to give his opinion, they are most welcome. Residents, any question? Any question? No? Nachi, Kuldeep, you're on. Thank you very much. Thanks once again for joining us. And thanks all the residents and faculty. Have a good day.